I'd like to thank Madam Chair for her kind words, and I'd like to thank the local organising committee here in Pune for inviting me to speak. So I'm going to speak a little bit about what is the point of care testing in cardiac surgery. I do have some disclosures. I've done some advisory work for Haemonetics, Roche, Optipharma, and CSL Behring. So what am I not going to tell you? Well, I'm not going to discuss really the area today of some of the common risk factors, which I think you all know about. You know, some of us work in units where we have wet or dry surgeons. Clearly, there are common risk factors for bleeding after cardiac surgery, such as age, the drugs you're on pre-operatively, and the time on cardiopulmonary bypass. So what I'd like to talk about is a little bit about outcomes, particularly around the area of transfusion and bleeding, because I think they are probably changing over a period of time, and challenge our thinking a little bit about what we think about them, what we've learned about them in the past. So this is Marco Ranucci's work. It was published in 2013. It looked at 16,000 patients over a 10-year or 12-year period. I want you to concentrate on the last column over here on the right. Sorry, this isn't very bright, this laser pointer. And in the white is the no perioperative anemia, and the black is perioperative anemia. And if you look at the last two columns, you'll see patients, thank you, who had bleeding, MB, and had plaqued red blood cells. And nearly 25% of the patients who bled and were transfused and were anemic before their operation died. So that's 25% of 1,400 patients. That's quite a large number. And that's quite an interesting finding. This is also one of the driest units in Europe. Their transfusion rates are around about 15% for all cardiac surgery in this Milan unit. So it makes you begin to think a little bit about the sort of lethal triad between bleeding, transfusion, and anemia. And it's quite a complex area, really, because when you bleed, you're probably going to get transfusion. Most of us know from retrospective data, or have learned from retrospective data, that transfusion may not be good for you. Now, I'm not totally sure about that when you look at the randomized controlled data. But what happens when you're transfused or you're bleeding is you often become anemic. And we're beginning to accept that it's okay to have patients anemic post-operatively, but we recognize the literature tells us that we shouldn't be operating on patients who are anemic before the operation. And I don't quite understand that paradox. So it's a complicated area. So what about bleeding now? There's some interesting definitions around bleeding. This is the sort of traditional cardiac surgical definition that you would use if you want to produce some sort of paper that gets published in the literature. And you define your patients as bleeding if they received 5 units of packed red blood cells, 1,000 mils of chest drain loss in 24 hours, reopening or the use of 7A. Now that seems pretty reasonable, but actually in clinical practice, is that really of any use? Because it's a bit late if you've had 5 units of packed red blood cells, you've lost 1,000 mils of blood. And in clinical practice, my definition is that you're bleeding if it takes more than 45 minutes for your surgeon, after you've given the protamine, to close the chest. Okay? Because it really shouldn't take that much longer normally. If you're in the ICU after your operation and you lose more than 2 mils per kilo for 2 consecutive hours over a 4-hour period, you're trickling. You're not really going to be able to wake that patient up easily. And you may think about whether you're bleeding. If you lose 4 to 5 mils per kilo, you're definitely bleeding. And clearly, if you're reopened for bleeding, you're bleeding. And that's a more clinical definition that I think is probably more useful. Bleeding often leads to reoperation. And reoperations in our unit have a poor outcome. And one of our trainees who came from India did this review with me. We looked at 2 years' worth of data from our unit. We managed to find 75 patients, about an instance of 3.6% of patients who were reopened over a 2-year period. And the most interesting finding is that 12.5% of the patients who were reopened died. Now, those patients' predicted mortality was 50% of that, 6.5%. So I thought, well, this is a bit interesting. And these were the causes of the reopening. And I thought, well, okay, we've got small numbers here. Thank you very much. We've got small numbers here, and Where's the button for it? Sorry. Okay. And we had small numbers here, and I thought, well, if we take out the patients who are arrested, are reopened for cardiogenic shock, they're the patients who are all going to die. That wasn't the case. Actually, it was all the patients who were reopened for bleeding that died. If you were reopened for bleeding, we doubled our tracheotomy rate from 4.1% in our unit to nearly 9.7%. If you were reopened for bleeding, the rate of renal replacement therapy doubled from 7.5% in our unit to nearly 14%. So reopening for bleeding in our hands, I would think probably generally, is a very bad thing to happen. So this is some data about transfusion practice in the UK. This was a snapshot audit done by the NHS Blood and Transport Unit, the Association of Cardiothoracic Surgeons and the Society of Cardiothoracic Surgeons, and we looked at 6,500 patients over a short period of time in 2013. In the upper slide, all the slides show the median transfusion. Each black dot is a specific unit in our country, and about 27 of the 36 units took part in this audit. The red line is the median transfusion level, and one can see that we give nationally about 50-odd% of patients will receive packed red blood cells at the time of their surgery. About 24% will receive platelets, and about 22% will receive FFP. So that gives you a place of roughly where we are nationally for all this, and that's roundabout, interestingly, where we are as a unit within that. So the real question is, can point-of-care testing or near-patient testing change this? Can it reduce bleeding, reduce transfusion, prevent reoperations? Are there simple devices that produce reproducible, accurate results quickly? Well, this is a near-patient testing lab that Vin has seen. This is our unit right in the middle of our cardiac operating rooms. We can do an RNR, APTR, derived fibrinogen, platelet count, and that hemoglobin, multiplate, platelet function, and TEGs, although those machines are being replaced by the new TEG 6 machines, which have a cartridge-based system that's very much like running an ACT. And we can get all these results in roughly 5 to 10 minutes for any patient who's just come off bypass or even pre-bypass. The important thing about any governance issues, if you're going to set up a laboratory like this, or you're using any point-of-care device, you probably need a quality control program, you need some training programs and log of the people who've done the training, and you need some way of incorporating your results in your clinical record. There's no point in having them lying around in loose bits of paper. It doesn't really work. So do point-of-care devices work? Well, this is the first small randomized clinical control trial done by Linda Shaw-Lesterson, and she used a relatively simple type of protocol where if you were bleeding, you needed a transfusion, you got randomized to standard control or some sort of TEG-based parameters to optimize your transfusion. And if we look at the circle on the right-hand side for packed red blood cells, fresh frozen plasma and platelets, we see a significant reduction in the amount of transfusion of all three areas when you use the TEG-based parameters in this trial. Then Michael Avidan comes along, and he does a really interesting trial where they do a point-of-care group, Hepicon, PFA 100 and TEG, versus lab group, versus an old dinosaur like me 20 years down the line as being a consultant and say, my opinion's best, I know what to do. Okay? And what we see with this is that actually they were able to get their standard laboratory RNA APTR results, platelet counts, back to the clinicians quickly, within about 10 or 15 minutes. So equivalent to point-of-care. So it doesn't really matter whether you use standard tests of coagulation or point of care. The results for transfusion are identical, but they are much better than clinical discretion. So old dinosaurs like me need to use something rather than nothing, because that reduces your transfusion. So here we have Klaus Gorlinger's work, and I want you to look at pane A in the left-hand side. This is a large retrospective study. And what they did is they changed practice. About 1,700 patients. In red is before 2009, blue is after 2009 when they changed practice. So the first set of columns you see are any autologous blood products, and they reduced it by using Rotem. they reduced the amount of packed red blood cells. The next column, they significantly reduced the amount of FFP they were using, and the next column, they increased the amount of platelets they were using. If you go to plate A on the right-hand side, you'll see what they did do is they increased the amount of fibrinogen concentrates they were using, and they significantly increased the amount of prothrombin complex concentrates they do. So what they did is they used a ROTEM-based algorithm to change from FFP to concentrates. And then they didn't count the concentrates as any allogeneic transfusion, so you then see a reduction in allogeneic transfusion, which is probably not true. These are plasma-derived products. But you do see a reduction in packed red blood cell use because you're using concentrates as opposed to lots of clear volume. The interesting thing about using concentrates is it reduces massive transfusion, it reduces re-expiration, and it reduces composite adverse events. Christian Weber comes along and does a small 100-patient RCT using this very complex transfusion algorithm that Klaus Gorlinger designed. And if we look at their transfusion rates, conventional group versus point-of-care group, we can sort of see that there's a reduction in transfusion and there's a reduction in costs, even when you take into account the costs of using the point-of-care machines. If we look at bleeding at 6, 12, and 24 hours, conventional group in red, point-of-care group in blue, we see a significant reduction in bleeding post-operatively despite a reduction in transfusion. So more appropriate transfusion, less bleeding. And then they saw an interesting decline in mortality, but they were quite honest about it and said, small numbers, we can't tell you very much about this. This is the latest data from Kevin Karkuti's group, published in Circulation in 2016. What it is a change of practice. They took 12 cardiac centres in Ontario. They took them a month at a time, and they said, right, we're going to collect your data, and then we're going to teach you how to use a ROTEM-based or point-of-care-based algorithm, and then you're going to use it for the remaining 6 months. And so each hospital moved along. So it's known as a stepwise cluster randomization study. It's a sort of way of doing a large RCT and collecting 7,500 patients without having to consent patients, because you can change an entire hospital's practice in one step. So it's quite a novel way of doing something, but they got ethical approval for it, and it seems to work. So this is the relatively simple transfusion algorithm they used. You come off, so you start at the top, you come off bypass, you reverse your protamine. If you're bleeding by measuring the weight of the packs in the chest for 5 minutes, and you've got normal point-of-care tests, you don't transfuse. If you're bleeding and you've got abnormal point-of-care tests, you do one of 3 things depending upon your results at the bottom. You either give a low platelet count depending upon your platelet count or your A10XM. You give fibrinogen or fibrinogen precipitate or fibrinogen depending on your FibTem, and you give factor, PCCs or plasma, and most people have got FFP depending on your CT-XM. Okay? So what did they show? And this is all patients, all transfusion. 45% of patients, whether you were in either group, got packed red blood cells. 25% of patients got FFP, 22% of patients got platelets. Interestingly, 25% of patients, by their definition, had a big bleed. That's quite a lot. Those figures are very representative of our data nationally in the UK that I showed you a few slides ago in 2013. Did they reduce transfusion? Yes, they reduced transfusion of red blood cells, they reduced transfusion of platelets, but not of plasma or cryo. They reduced transfusion of or massive bleeding. But one of their major endpoints, they said, is that this is going to change complication rates, because they said, well, transfusion and bleeding are related to long length of stay, ICU, and mortality. Absolutely no difference. It didn't matter what you did, you can reduce your transfusion, it makes absolutely no difference to your mortality, to your complication rates, or your length of stay. So, just to try and summarize all this data up and say, should you be using point-of-care? Well, if I'm absolutely honest with you, I think bleeding that ends up with transfusion is of uncertain importance, really, because I think, if you're bleeding post-bypass and you give some plasma, cryo, platelets, whatever you're going to give, PCCs, we use a lot of prothrombin complex concentrates, I think you're managing bleeding appropriately, and the important thing is to try and get the patient out of the operating room dry. I think if you don't manage that bleeding appropriately and you end up with a patient who's bleeding in the ICU, that leads to a certain degree of complications, and that's not good. So the important thing when you want to think about this is, what can I do? And we can talk about the complexities of coagulation, but frankly, as an anaesthetist in the operating room, we can give fibrinogen, we can give FFP or plasma generators, or we can give platelets. It's relatively simple, regardless of the complexities of coagulation. So we can make sure somebody's fibrinogen is adequate, but remember, it's the first plasma protein to disappear. If you're going to convert fibrinogen to fibrin, you've got to have adequate thrombin generation. And to get adequate thrombin generation, you've got to give plasma in a good dose, 15 mils per kilo. You've got to give PCCs, prothrombin complex concentrates, in 20 mils, or you might occasionally have to give them 7A. You've got to have an adequate number of platelets that are functioning. And what is that adequate number? Maybe somewhere between 75 and 100 post-bypass, providing they're functioning, to be able to form a platelet plug. And if you do all of that and assist all of that process, your patient will probably be dry. So in conclusion, we use a lot of point-of-care near-patient testing. It will lead you to reduce transfusion. It will lead you to appropriate transfusion, often. It will help you or target your patient to make sure they leave an operating room dry. But there is no evidence to date that it's going to change your outcome of your patients. It's not going to affect their length of stay or their mortality or their complication rates. Thank you very much.